Good afternoon, everyone. Thank you all for dialing into NIDA's HIV seminar today. We have a very special seminar scheduled today titled Let's Talk PrEP. Today's seminar will be given by a panel of distinguished scientists working in the space of HIV prevention and a special guest who will share her own unique experiences with PrEP. Pre-exposure prophylaxis, or PrEP as you all know, is a proven way of preventing HIV. Yet it is highly underutilized in populations at risk for HIV, such as people who use drugs. Today's seminar is put together to highlight current knowledge on PrEP, PrEP uptake in prioritized populations, and the recent advances we have in PrEP medications. With that, I would like to now welcome the first speaker on the panel, Dr. Rupa Patel. Dr. Patel is a PrEP clinic medical advisor at Whitman Walker, and she is also the clinical biomedical prevention activity lead in the Division of HIV Prevention at the Centers for Disease Control and Prevention. Her research interests include developing healthcare access for marginalized populations such as people living with HIV, LGBTQ people, people in underserved racial and ethnic groups, people experiencing injection drug use, and sex workers, both in domestic and international counterparts. Her presentation for today is titled PrEP Implementation, Where We Are Today. Welcome, Dr. Patel.
Thank you so much, and thank you for the organizers for allowing me to present today. I'll be covering PrEP implementation with a focus on long-actings today, and I'm the CDC Clinical Biomedical Prevention Activity Lead. So first I'll outline our prescribing trends, then review long-acting, then I'll go into some of the implementation barriers and successes across the nation. First, I want to give the audience an overview on essentially the pipeline. We need to get energized and excited. We need to be passionate about the fact that we have so many modalities today. We've got oral PrEP. To the right of the slide, this is a great slide from AVAC. For those that are interested in PrEP, I highly recommend for you to go into the AVAC website. So what do we have today for the toolbox of biomedical prevention? Well, in addition to U equals U, and male circumcision in terms of public health prevention for preventing HIV transmission and getting our nation to zero new infections, we also have oral PrEP, or the use of medications or antiretrovirals to prevent HIV before the exposure. And this is different than post-exposure prophylaxis. Today's PrEP is 99% effective for sexual transmission and at least 80% effective when using oral medications for injection drug use transmission. With that, today's oral PrEP is on-demand 211 as well as daily oral PrEP. And now we've got the era of an injection. What I wanted to talk to you about is when you look at everything in development, all the colors are new medications and all the actual symbols are the types of PrEP that are being developed. So we've got injections, we've got pills, we've got short acting, long acting, we've got douches, we've got rings. It's really a great paradigm, and we've got to implement what we have today and have lessons learned for us to implement tomorrow's PrEP. And so just to give you the state of prescribing today, from 2013 to 2023, remember we first FDA approved PrEP in 2012, you have a total of 1.1 million users. And in terms of long-acting injections, we've got of that, only 2.5% are roughly cabotegravir users when we look at 2022 and 2023 numbers. And so relevant to this talk, just this year, there was a national survey analysis in 19 cities of PrEP use and awareness among persons who inject drugs. And what was the startling finding is in red, where we really had low and stable PrEP use of 1%. So it's estimated 1 out of 100 persons who use drugs or inject drugs are actually using PrEP. in contrast to about 35% or 1 out of 3 injection drug users who actually know about PrEP. And in terms of the slide, the figure on the bottom, essentially you're seeing the use and awareness by subgroups. And I want to highlight you to the box in the bottom of the slide that's in red. You know, when they looked at injection sharing, and equipment sharing, and you know, syringe sharing, you saw elevations in PrEP use over time, and that was statistically significant. I highly recommend you to look into detail at this CROI conference poster that was presented in 2024. And then I'm going to direct you to some of the current barriers around PrEP, because as you are researchers, you're program implementators, you're really involved in implementation of PrEP. Let's talk about the barriers we already know. This was a large 2024 study at the CDC looking at prescription databases, and we saw that 1 out of 3 people that were commercially insured were still paying out of pocket for an office visit, a lab, all the ancillary services, not including the medications for PrEP, despite our Affordable Care Act preventive protections. And 50% of these costs were provider visits. So as we are researching or performing implementation studies, I think understanding and outlining the barriers to cost and some of the funding solutions that exist at the state level that your state or program has been using, such as 340B, is really important to document for policy implications. Next, I want to just talk to you what we have today from the CDC. We have guidance on long-actings, which today is Apretude. For those that have never seen it, it's a box. You open the box, you have to put the needle together, draw the vial. You know, this is a clinical geared talk for those of you that are writing these grants, just to give you the layout of the steps that it takes to actually administer the injectable form of PrEP, which will be some of the future barriers we'll see with future products. So essentially, after you draw the vial, you'll inject it. And this is considered an actual medical service requiring licensed professionals, which we've then encountered this certain era of re-medicalizing PrEP, when you used to be able to go to a pharmacy and just get a prescription of oral pills. I want to remind everyone, we essentially also had a grade A recommendation by the U.S. Task Force. That's important for you because that allows insurances to cover it. And I'll show you today's barriers around getting cabotegravir is actually insurance related, and we're documenting that. This is a snapshot of the clinician guideline. It's just table 1B. I highly recommend you print it out, put it in your clinic, put it in your office. These are elements you have to write into the grant many times, or at least assess. I highlighted the boxes in red for you because every 2 weeks is very cumbersome. You know, remember, oral PrEP is every 3 months as a visit. This is in contrast to an injection that has to be delivered every 2 weeks. It's considered re-medicalizing. People are having a hard time taking off work. And so these are some of the indications of why you might have discontinuations. So documenting your PrEP injection care continuum of who's discontinuing and why is really important for equity. In addition, you've got testing, you know, with an RNA testing that has been some barriers at the clinic level. And again, I can open up to Q&A. I know these are very detailed conversations about the clinical aspect, but we have seen these actually coming out in qualitative work and quantitative work when you assess clinics and their inability to actually roll out injectable PrEP in their long-standing PrEP programs, oral PrEP programs. To direct everybody, this is very fascinating. We have a wonderful PrEP curriculum that's been created with a lot of interactive 3D modules and graphics for injecting. This has been very important when you're taking individuals who've never given injections, you know, nurses that have wanted to start doing injections, or as we'll talk about, task shifting to medical assistants and lay workers and some of the program solutions I described. These modules have been very great. And then there's these even these sample clinic flows that have been developed, and this was a ask by clinics to have this. We have a hotline that I think people don't know about as much as we would like to have that dissemination goal, maybe an underutilized hotline. This hotline is great. It can take you step by step. It can talk about examples from other locations as well. And then you've got large technical centers to the bottom of the slide to the right, through HRSA and through the CDC, that both span, STD treatment and prevention, as well as HIV, and that syndemic approach that we're trying to highlight. This slide is really just to gear you towards how complex the workflow is, and to maybe get you up to date of what long actings in the future may look like if they are injectables or implants, which we're all hoping for. The next injectable slated to come out in 2025 will be lenacapavir. Hopefully FDA approved in June or July. It's an every 6-month injection. It's a game changer. It's in the stomach, like subcutaneous, like insulin. So really very easy to administer, will help us overcome challenges with oral PrEP. But you got to get the workflow correct for today's PrEP. So on the left-hand slide in the gray, that is all the insurance acquisition. You got to buy the med, you get reimbursed, you need prior authorization, you got to ship the injection, store it, document it. Then you go to the blue boxes, which is, scheduling appointments, missed appointments, getting everyone in every 2 months. Then you've got to actually document care, have your medical documentation, look at injection site reactions, document discontinuation, and then you go into medical documentation. So these are actually some of the questions for research that we're always asking about. Who's getting it? What are the disparities? I've written the questions in green. What are the insurance denials? Who's discontinuing? Why? Who's getting on-time injections? Are we meeting our outcomes for efficacy and effectiveness? And then implementation strategies. These are my last 2 slides. This great article from Emory University really ironed out their implementation process for treatment injections, which we've applied lessons learned to prevention injections, details it line by line. This long pre-implementation phase has been a winner for a strategy, including hiring dedicated injection or long-acting coordinators, injection task shifting, creating clinics, pop-up clinics, flexible clinics, walk-in clinics. And then remember, the policy implications of injectables are really important about task shifting. A syndemic approach, can you also give your gonorrhea and syphilis injections at the same time? And some examples of clinics that have presented at conferences are Philadelphia Fight, Whitman Walker Health, Legacy Health, and then also the San Francisco Public Health Department system. Lastly, in conclusion, as an overview, PrEP use is low. We know that, but we've quantified it this year. Implementation is slow for oral PrEP in the group that we're talking about today, and even including injectables nationwide due to access and implementation barriers. And we really have to have the lessons learned for today in order to get tomorrow's products, really implemented in an accelerated way. So I want to thank you for this talk, and I'm going to transition to Q&A. At this point, I am just going to open the box and see if we have some questions. The first ones I see is there any information on injectable CAB uptake among people who inject drugs? That is a very good question. Thank you. We don't have any national data at this point because, remember, prescription data doesn't allow you to look at behavioral risk or any type of risk. If anything, you're just getting geography and age from these databases. So the call to action is you in the audience as researchers to do as much documentation as you can. We have some early insight from San Francisco. They presented last week at R4P. In these slides, I had that citation And what they showed is that of 111 people that they serve with cabotegravir injections, in general, 50% of those people were persons who use drugs, not necessarily injection use. And what was startling is those who identified as using any drugs during their time were 2 times more likely to not get the injection on time on their follow-up injection. So a lot to really document on how we can do this. And you need to set the stage for lenacapavir. As these new products come out, create your databases, figure out how you're going to work with your clinics and your programs to see what the gaps are. Next, I have a question about, we work in an environment where we are unable to screen for syphilis, gonorrhea, but we'd like to roll out PrEP ASAP, aim to roll out STI testing, but can you do this now? At this point, wherever you can serve anybody that's at risk for HIV, I think that's important. Remember, the very basic is an HIV test. I think we always want to look at STI, so gonorrhea, chlamydia, and syphilis whenever we can. I just want to make sure we delineate PrEP does not prevent STIs. That's a misnomer. PrEP only prevents HIV, and you need an HIV test routinely to make sure someone's not HIV infected, and then you're giving them antiretrovirals. And I think then you incorporate the STI testing, which we strongly encourage, but we do know that there's limitations in each clinic. I'm going to go into the next question. Is lenacapavir self-administered? It is a product that's not out yet. Will it be self-administered? That is yet to see in the FDA label, but many people have been advocating, stakeholders in general, for self-administration. I want to highlight cabotegravir today, that's FDA approved. We'll likely have an every 6-month formulation in the future as well. So that may have self-administration, and in the pipeline is also a once-a-month oral pill. The studies are just getting underway, so I really want to highlight long-acting has a new era, and as researchers, finding what are the preferences and maybe discrete choice experiments among the population you're serving is very important and an unmet need in research. The next question, can you say the percentage of uptake for PWID and transmission risk? In PrEP in general, I don't have those numbers, but that 19 city study is the closest we have, and you can actually download that poster from the CROI presentation. What are your thoughts on pharmacists having the ability? Thank you. Task shifting is very important, or task sharing, and we consider pharmacists. Many of the clinics that I described in the study, including Legacy Health, are entirely administered by pharmacists. Pharmacists are injecting, are determining clinical eligibility. And so we're at time right now. There's about 4 or 5 other questions. We'll get to those by email. I appreciate your time and all your enthusiasm and engagement, and I'll turn it over to you as the moderator.
Rupa, thank you so much. That was a fascinating talk, and thank you for making time, although you have another conflicting event right at this time as we speak. And this is very informative, and hopefully the talk will be available online, so if people who could not dial in, they will be able to access it any later point. Thank you. Okay, so let us now go to the next speaker we have on the panel. That is Dr. Jamie Mayer. She is an associate professor of medicine and public health at Yale University. She is a physician scientist with board certification in internal medicine, infectious diseases, and addiction medicine. Her NIH-funded clinical research is centered on HIV prevention and treatment for women, addressing social and structural determinants of health. Her clinical work and research are motivated by her experience working as an HIV care provider at the only women's prison and jail in Connecticut. So her presentation today is titled PrEP for Key Populations, Women and People in the Criminal Legal System.
Thank you so much, Kavi. Thank you. It's great to be with you all today. I'm really honored to be invited to speak. And as she just mentioned, I'll talk to you today about PrEP for key populations of people with substance use, with a focus on women and people in the criminal legal system who are also sometimes women. Here are my disclosures. So as you just heard, there are nearly 38,000 new cases of HIV diagnosed in this country every year. So we have a really long way to go to get to the ending the HIV epidemic goal of just 3,000 by 2030 and hopefully someday getting to zero. And that's why one of the major pillars of the EHE epidemic is prevention. As you've just heard as well, we have seen a steady rise in the number of new initiations of PrEP over the past decade since it was first introduced and FDA approved. So great news, right? Why aren't we making a dent in new infections? So part of that is because health disparities persist. The people who experience the greatest burden of new HIV infections are also the least likely to be covered by PrEP. And this has to do with healthcare access, right? So if we look along the x-axis here about trends in time, and the y-axis is PrEP coverage by percent, we see this sharp rise in new PrEP initiations among people who are white, and yet people who are Black or Hispanic, Latino have a much flatter curve, right? A little bit of a rise, but pretty flat in comparison. Sex and gender-based disparities also persist. So a really sharp uptick among people who had male sex assigned at birth, and yet a much slower rise among people who had female sex assigned at birth. And this results in an adoption gap, such that of all the people who could potentially benefit from PrEP, only about a quarter have actually received it. And that's 2019 data. So if you look at 2022 preliminary data, maybe the coverage is closer to 36%, but we've got a long way to go. And if you look at the disparities, they are there definitely by sex and gender, by age, by race, ethnicity. And so we know that women with substance use have really been underserved by PrEP. Only 10% of women who could potentially benefit from PrEP were prescribed it back in 2019, which is the year the EHE initiative was introduced. So this suggests that we really need differentiated service delivery for key populations. We need to modify how we deliver PrEP to reach people who need it the most, who aren't being reached right now. In the latest iteration of the Consolidated Guidelines on HIV prevention, diagnosis, treatment, and care in 2022, the World Health Organization focused on 5 key populations: men who have sex with men, people who inject drugs, gender diverse individuals, sex workers, and people in prisons and jails. And so I'll talk about 2 populations right now that kind of overlap and spread across those 5. Women with substance use are a key population for HIV prevention because they are at substantive risk of HIV. So when I'm talking about women here, I'm primarily talking about cisgender women, that is, people who had female sex assigned at birth and who identify as female. And there are certainly really important issues for delivering PrEP to trans women, but those are distinct, right? And so as we're thinking about differentiated service delivery, we need to think about exactly the population we're trying to serve. Women with substance use experience HIV risk, certainly because of their injection drug use, but also because of other substance use. They may be within networks that are high risk. A lot of times women are having sex and using drugs with the same people, so there's overlapping risk there. They may be exchanging sex, either for money, drugs, or just to meet their basic subsistence needs like housing, food, transportation, right? Women with substance use often have reduced social capital or agency to negotiate condoms with their male partners, especially if they're experiencing intimate partner violence, which we know is quite common among women who use drugs. And all of those things together mean that we need PrEP as an additional HIV prevention tool even more. Women with substance use experience increased risk of bacterial sexually transmitted infections like chlamydia, gonorrhea, and syphilis, which you just heard about, all of which facilitate HIV transmission. And also, the fact that they experience a lot of times stigma, shame, other social determinants, all of these things together deter people from accessing care and services. So this is really the power and potential of PrEP for women with substance use. It's highly effective at preventing HIV in cisgender women, especially when adherence is supported. There are lots of formulation options. You just heard about even more coming down the pipeline. All of these are supportive of patient choice, right? So we have a daily oral pill, which is FDA approved for cisgender women, tenofovir FTC. We have long-acting injectables. Cabotegravir is already FDA approved for people whose HIV risk is through sex. And hopefully the approval will be extended for people who inject drugs as well. And you heard about lenacapavir, which will soon hopefully be FDA approved. And then we have vaginal rings also available. For women with substance use, it's exciting that PrEP is fully user controlled. So unlike condom negotiation, no partner participation required. It is discreet, and that may be particularly important for people who don't want to disclose their risk to partners, and event and risk behavior type dependent. It works if you're having sex, it works if you're using drugs, right? Regardless of your partner. But there are lots of barriers to access for women with substance use. Some of these are at the individual level. Women might not have knowledge, awareness of PrEP. They might not think it's relevant to them. They might not even be aware of their HIV risk, or they might be underestimating their HIV risk. And then there are all these social, organizational, community, societal, structural level barriers that place demands on patients and make it harder and harder for women with substance use to be able to access PrEP. So how can we overcome implementation gaps? There's really no right answer here, but here are just some ideas of things that we know do work, could work, might work. One is a messaging shift. PrEP is empowering, right? PrEP is something that you can do to manage your own HIV risk. PrEP is relevant to you, right? Women need to see themselves in the messaging, right? If we only have pictures of a certain type of person who looks a certain way or acts a certain way, then women aren't going to see themselves in the messaging. For existing infrastructure for PrEP, we want to lower barriers to access, make it easier for people to get there, right? Whether that's transportation, childcare, anything else. Extended hours, you name it. And then we need to think about integrating PrEP into places where women with substance use are already accessing care and services. And that's because existing models of care are insufficient to meet women's needs. We need a no wrong door approach. Like, you should be able to get PrEP in your primary care setting, yes, but also women's health centers. And a lot of places do, but that's a significantly underscaled area. People might not get health care at all, but they might go for their pap smears, right? So thinking that through. Drug treatment settings. There are a lot of non-clinical service settings where people are potential points of contact, right? Domestic violence service settings, homeless shelters. You're going to hear in a moment about syringe service programs and harm reduction programs, sex worker alliances, community outreach programs, right? All of these things can be places to provide PrEP education, do HIV testing, do patient navigation to PrEP care, linkages to care, or in some instances, dream world, PrEP on site. And then also carceral systems are an important point of contact, potentially for PrEP for women with substance use. It kind of segues me into my next key population here, which are people in the criminal legal system, some of whom are women. So why are we talking about this? The U.S. incarcerates more of its citizens than any other nation worldwide. And 1 in 5 incarcerated people in the world is incarcerated in the United States. The US also incarcerates more women than any other country worldwide. So you see tens of millions of people who are directly impacted by involvement in the criminal legal system. And people in the criminal legal system are a priority population for HIV prevention because they are at substantive risk of HIV. So when I'm thinking about the criminal legal system here, I'm talking about sort of three general buckets, and often people travel back and forth between different settings. So there are carceral settings or closed detention settings like prisons, jails, detention centers. There are community supervision or community correction settings like probation or parole. And then there are judicial systems or courts, right? And so lots of different ways that people move through the criminal legal system. But there is a very high prevalence of substance use in this population. Over half of all people in state prison systems have a substance use disorder, compared to 7.5% in the US general population. And they have very high HIV risk. Incarcerated people are 7 times more likely to have HIV than the general population, but people's HIV risk really happens on release. It's when they're transitioning from carceral settings to community settings and life is chaotic and hard and there's lots of competing priorities that their HIV risk is the highest. They often have comorbidities that increase HIV risk, like hepatitis C and sexually transmitted infections. And there are tons of social and structural determinants that reduce access to HIV testing, care, and prevention. Racism, stigma, insurance, housing, all the things. It's really hard to get data on PrEP access behind bars. But some of my colleagues did a survey that they sent to 1,126 jails, and there were 327 jails who completed this survey. And they found that just 7% of all jails offer routine opt-out HIV testing on admission, which is sort of a standard of care, so dramatically underscaled there. And most of the testing and screening is done by non-healthcare personnel. So if we're thinking about the status neutral continuum, it starts with an HIV test. And, if you don't have that, you're never going to get to PrEP, right? Only 9% of jails offer PrEP to people who request it. That seems, kind of low, very low. And just 16% of jails provide referrals to PrEP on discharge planning, which seems like kind of a low-hanging fruit. There are lots of different ways we could think about expanding PrEP to people in the criminal legal system, right? So during incarceration, this is one way we could need to, there's lots of room to grow, right, to deliver PrEP during incarceration. It requires internal champions, both from system administrators, but also from potential recipients. Incarcerated people themselves need a seat at the table if it's going to be done right. We need to train up clinicians. So as long as PrEP requires a prescription, we still need prescribers. And we have to establish protocols specific to implementation in carceral settings. And I know in some settings that's being worked on. In terms of discharge planning, that starts on admission, right? So this is a first opportunity to kind of think about when someone leaves this setting, how can they be linked to PrEP back in the community, if nothing else, on the back end? And there's emerging data that patient navigation services on discharge work really well for that. And then we need to think about expanded community access. We want expanded access both for treatment of substance use disorders and mental health care, and hopefully help people avoid incarceration altogether, but also expanded community access for PrEP because people need a place to land when they come home. So I just wanted to close with an example of an ongoing project where we're working to address PrEP access for people, for women in the criminal legal system, really talking through some of the issues that we just discussed. So we were grateful to have received a NIDA R01 for a project called Athena, where we're asking, can we use telehealth to deliver integrated PrEP and medications for opioid use disorder to women who are involved in the criminal legal system. They're all living out in the community, so they're on probation, parole, or recently returned home from prison or jail. Enrollment is ongoing, though our goal is to get to 250. This is a randomized clinical trial. Everyone gets a decision aid about PrEP that our team developed and is specific to women with substance use disorders. And then they either get their telehealth for integrated PrEP plus MOUD or referrals out for PrEP plus MOUD, which is sort of treatment as usual. We're really interested in the implementation questions across diverse settings. So we have a site in New Haven, Connecticut, and a site in Birmingham, Alabama, where my colleague Ellen Eaton is the site PI. And we look forward to sharing those results hopefully in the near future. But in the meantime, we're learning a lot about sort of what works and what doesn't work. And that's it for now. I look forward to taking questions later and more discussion. Thank you.
Thank you, Jamie.
Thanks.
All right, move to the next speaker on the panel, Dr. Hansel Tukes. Dr. Tukes is a tenured professor of medicine at the University of Miami Miller School of Medicine. His research focuses on innovative interventions to improve health outcomes in people who inject drugs, as well as structural interventions and innovative approaches to HIV prevention and treatment. He is the founder of the IDEA Lab, which houses a citizen services program, the first of its kind in Florida. In 2021, Dr. Tukes received a NIDA Avenida Award, which is supporting the innovative research project titled Teleharm Reduction for Rapid Initiation of Antiretrovirals for People Who Inject Drugs, a randomized controlled trial. His presentation today is titled Teleharm Reduction for the Prevention of HIV Among People Who Use Drugs. Welcome, Dr. Tukes.
Thanks so much, Kavi. I remember talking to you about that DP2 back in the pandemic. I'm so excited to be here today to talk to you about teleharm reduction. Interestingly, I'm at the NIDA CTN meeting, and we had our first participant in the trial who randomized to the intervention, the trial that I'm about to tell you about. So very interesting real world application. Next slide, please. So adapting Merrill Singer's syndemic theory, we see that there is a tremendous psychosocial and structural burden that act as barriers for people who inject drugs in entering care. That includes co-occurring mental health disorders, the stigma that is pervasive in the healthcare system, HIV, hepatitis C, all compounded by lack of access to healthcare, lack of access to technology, lack of harm reduction services, incarceration, as we just heard about, homelessness, loneliness, and racism, as well as poverty. One bright spot in the pandemic has been the shift to the telehealth delivery of services. And telehealth is supported by the Infectious Disease Society of America and is grounded in evidence. What we see is that an innovative approach rooted in harm reduction is urgently needed for people who inject drugs. And I feel very strongly that we need to take healthcare out of the traditional healthcare system and to the people. Next slide, please. So we looked at telehealth adoption during the first year of the pandemic, and we found that 30% of programs reported implementing telehealth-based services during this time. In multivariable logistic regression models, community-based organization syringe service programs had higher odds of implementing telehealth services compared to public health department SSPs. We also found that SSPs that received governmental funding had higher odds of implementing telehealth medical services compared to programs without governmental funding. There's a large missed opportunity to engage a highly marginalized and long overlooked community at SSPs and via telehealth, especially in areas of high need like the South. I truly believe that telehealth is an exciting new opportunity for us to pursue health equity for people who inject drugs. It's a promising strategy to overcome this inequality, which leads to health disparities, but it needs to be supported by tailored implementation strategies that match the diversity of programs not only to enable SSPs to implement evidence-based interventions, but also sustain these interventions over time. I'm going to tell you about teleharm reduction. So what is teleharm reduction? It's basically bringing healthcare to people who inject drugs via technology. Next slide, please. We designed teleharm reduction in equal partnership with the community that we serve. They were in the room as we designed the intervention and wrote the grants. It's a peer-driven intervention. The peer is truly the center, the secret ingredient to all of our successes. It's telehealth enhanced, it's on-demand services, low barrier access to PrEP, antiretrovirals, medications for opioid use disorder, Hep C treatment, and mental health services, so that on demand, it really is concierge medicine for people who actually need it. There's mobile phlebotomy, there's harm reduction counseling and medication management, and all of these medical services are integrated with the provision of evidence-based naloxone and injection equipment. We're trying to meet people where they're at and on their terms, respecting their autonomy. And there are decades of evidence of this approach in primary HIV prevention via syringes. Next slide, please. So just to hammer it home, the patient is at the center, and the peer harm reduction counselor, you see the heart because the peer always leads with love, brings the iPad to the patient wherever he or she's at and connects them with the physician or the psychologist. The physician is able to prescribe medications which are delivered to the patient with core harm reduction supply. So with syringes, with naloxone. And in this cycle, there's the opportunity for ongoing motivational interviewing. Next slide, please. So we developed teleharm reduction under the DP2 grant for the rapid initiation of antiretrovirals amongst people who inject drugs who are living with HIV. And in our pilot study, of the 35 people who engaged in the teleharm reduction intervention, at 6 months, 78% were virally suppressed. And this is one of the highest viral suppression rates that I've seen reported in people who inject drugs. We are currently randomizing for the T-SHARP trial. So that's telehealth solution for HIV and addiction-related problems. It's underway, it's funded by the DP2, and we have 91 randomized to date. What's the opportunity that we have now is to make the intervention status neutral, and that brings the Chariot trial, which is the companion trial to T-SHARP. Next slide, please. So when we sought to adapt the teleharm reduction intervention to be status neutral, where people are treated according to their needs and not identified according to their diseases, we won an EHE planning grant in which we asked Black people who inject drugs, a long overlooked community, how we could best help. And what they told us, you can see here on this manuscript, we want everything in a one-stop shop. So that included PrEP, that included buprenorphine, that included mobile syringe services to help folks prevent HIV. They wanted the one-stop shop. So in the Chariot trial, which is comprehensive HIV and harm reduction via telehealth, Dr. Bartholomew and Dr. Barocas, my partners, we submitted an R01 in pursuit of a one-stop shop, a hybrid type 1 effectiveness implementation trial of comprehensive teleharm reduction for people who inject drugs. This trial is underway at IDM Miami, the first person randomized to the intervention today, and I just took that meeting for that visit in this room. Our primary aim is to evaluate the effectiveness of comprehensive teleharm reduction on PrEP and MOUD initiation and retention. Dr. Barocas will be leading the second aim, which is to evaluate the cost effectiveness, and long-term clinical impact of comprehensive teleharm reduction. And our prevention scientist and implementation scientist, Dr. Tyler Bartholomew, will be leading the implementation work, assessing the implementation process and scalability of comprehensive teleharm reduction. Next slide, please. So in our adapted model for teleharm reduction, we were excited to publish this manuscript led by Dr. Eddie Suarez, who is our psychologist on our team. And we had a cohort of individuals who we enrolled in low threshold buprenorphine on site at the SSP. At 3 months, we had a 59% retention. However, baseline stimulant use decreased the odds of buprenorphine retention at 3 months, but seeing a provider via telehealth increased the odds of being retained in buprenorphine at 3 months. So we saw that telehealth truly facilitated both initiation and retention in buprenorphine care for people who inject drugs. So the Chariot trial is underway, and we will randomly assign individuals to either receive the comprehensive teleharm reduction model or referral, and then we will follow people for 1 year. But what does PrEP engagement look like in this new exciting PrEP environment? We had 90 people in our oral PrEP pilot, and we had a lot of initiation success, but significant challenges in retention. At 1 month, our retention rate was 72%, and at 12 months, it was actually 31%. And we haven't published that information yet, so you're the first to know these disappointing findings. And so we need to find ways to overcome these barriers. I'm pleased to share with you some results from Dr. Eddie Suarez's acceptability and feasibility of long-acting injectable PrEP. This is a qualitative study with SSP participants and providers that he conducted in Miami. And clients expressed enthusiasm at the possibility of long-acting injectable PrEP implementation, and providers were similarly supportive. You can see some of these illustrative quotes here. They should have had this a long time ago. This is something that I would really, really appreciate. And then the provider said, in general, and for people who inject drugs, I think it's a great development. Next slide, please. All clients expressed challenges in taking oral PrEP on a daily basis due to factors related to their substance use and or insecure living conditions, which could potentially be avoided with long-acting injectable PrEP. One client said, it's just like a given when you're out on the streets, people steal your stuff. And this is all compounded by the street sleeps that plague our nation at this time. Another client said, one thing about injecting drugs, shooting drugs, smoking it, having it, one thing we do, and I'm speaking from experience, we forget to eat, we forget to drink, we forget to do a lot of things, hygiene. I can imagine forgetting to take a pill every day would probably be the last thing we're probably thinking about. So everybody identified the challenges and saw long-acting injectable PrEP as a way to overcome the challenges of daily PrEP adherence. Next slide, please. Finally, these challenges were noted by all of the providers. One provider said, I've had a hard time knowing if patients are taking it or not. Another said, I think adherence is really poor, and I think people go on and off PrEP all the time, which is obviously not ideal. In contrast as to the challenges of daily oral PrEP, all of the clients expressed excitement regarding the use of long-acting injectable PrEP and the ease of use, namely taking only 1 injection every 2 months. They said, I'm not going to lie, I've missed maybe a day or two or whatever, but doing that once every 2 months sounds so much better and easier. It sounds great. Another said, I'd have it in me and I don't have to worry. Finally, one said it would cut down on the things that they have to keep track of. So cabotegravir and lenacapavir integrated into a teleharm reduction framework provides opportunities to address the challenges in adherence to PrEP for people who inject drugs. I imagine that this evolving PrEP practice will be elucidated through our implementation aims of this trial. And we're also extremely excited to be a site for HPTN 103, which is purpose for lenacapavir in people who inject drugs. Next slide, please. I encourage you to watch these videos that tell the beautiful stories of the work that we're doing in Miami. It really provides the essence of the teleharm reduction intervention. You hear it from the folks who are benefiting from these innovations. I hope that with my presentation, it is clear that with teleharm reduction, we really seek to lay the foundation for an enhanced model of care for people who inject drugs to both treat and prevent HIV. We want to transform the way people who inject drugs access healthcare, and we want to forge a pathway towards ending the HIV epidemic in this high priority community, overcoming marginalization and stigma by meeting people who inject drugs where they are. I have to give thanks first and foremost to our IDEA participants. They've given me every idea that I have, and it's an honor to represent them in the State House as well as in the Academy. I thank my fellow IDEA faculty, especially Dr. Tyler Bartholomew and my mentor, Lisa Metch, as well as my dean. So now I have the great pleasure of introducing one of the IDEA family, Sherry.
Hi.
Hi, Sherry. It is so nice to see you. Thank you so much for joining this group of researchers.
No problem. Thank you for having me.
I wanted to give you the opportunity first to introduce yourself to the people who are on the seminar today.
Okay, hi guys. My name is Sherry Millward. I'm 38 years old. I've been an IV user for the last 6 years. I've been homeless for the last 6. That's pretty much my introduction, right?
You know, I'm just so proud to have you as part of the IDEA family, and you know, Sherry's generosity in sharing her story is so typical at IDEA. Everybody wants the best. They want to share their story if it can help other people, and I know sharing with researchers first and foremost is a priority. My first question for you, Sherry, is when did you start PrEP and why?
I started it about 4.5 years ago. I started with a research thing that you guys were doing on people introducing PrEP to us. That's how I started taking it.
And how did you make the decision that you wanted to take PrEP?
What decision was there to be made? After hearing what it does, there's no questioning it. I would be stupid to question it.
Well, I'm happy that our research, you can see firsthand that research can have immediate positive outcomes by encouraging folks to start PrEP. What was your experience accessing PrEP and seeing the physician and getting the prescription?
That was pretty much easy. You know, there were some days where it was harder to get to where I needed to go because of, you know, being a drug user. I needed to get my fix. Not wanting to go, being sick. But when I did get here, it was no problem. It was in and out, no questions asked. It was completely satisfying.
That's amazing. So did you access PrEP both at the fixed site and on the mobile unit?
Yeah, yes, I did.
Okay. Do you think that syringe exchanges are an appropriate venue to deliver medical care, like accessing PrEP?
Not at all. You know, we don't have many people out here helping us. So any type of help that we can get, and it's a game changer. So it's definitely not a problem.
So you do think it's an appropriate environment? Because, you know, when IDEA first opened, we were just one shipping container and we were just exchanging syringes. And through time, we've evolved. We've been listening to you. And we wanted to create a nice, non-stigmatizing environment for you to access medical care. And I hope that you feel that at IDEA.
Absolutely. You guys have, anytime I have needed anything, you guys have been there like I've been family.
We are family.
Yes.
So how do you find taking PrEP every day as a daily pill?
It's hard, you know, being homeless out there, and you know, being on fentanyl, nodding out, getting myself stolen at least every other day. Being selling myself, selling myself, I'm sorry, what was the question?
You know, Sherry, your bravery in sharing your story, including sex work, is just extraordinary generosity, particularly with this group of faceless researchers that's on. I was asking you what your experience was taking oral PrEP every day.
Sorry. It's kind of been a struggle. Like I said, not being able to get to where to get to you guys because I'm sick. I don't want to move. I'm honestly not caring about it at this moment. Trying to figure a way to come up with some money. So it's been hard to take it every day, but it's pretty much it's hard to have to take a pill every day being homeless. Like you said, you know, we don't want to eat. The last thing we care about is taking a pill.
Have you felt empowered protecting yourself from HIV?
I have felt so empowered. I hang out with a group of 5 girls, and 3 of them have HIV. The one girl, I don't even know if she has HIV because she has moved away. We share the same needles. I didn't know they were HIV positive. We have shared the same needles. We've had sex with the same guys. Just being raped out there, not having a chance to make that what do you call it? The having the right, having the choice to be protected or not. So it's been amazing to have like that. It's like an extra guard up. It's like an extra prevention, and I honestly think it has saved me because, like I said, the same people I hang out with have got HIV. We have shared needles. We've shared everything together.
I'm so grateful that you've been empowered in times where you haven't had the ability to negotiate condom use. And I'm so sorry for the sexual violence that you've experienced on the streets of Miami. It truly breaks my heart. Do you think that if you had access to, well, first, have you heard about the injectable PrEP? I know you heard about it today. Was that something that you knew about?
I heard about it recently.
And so what do you think in terms of the current schedule, getting an injection? It is an intramuscular injection every 8 weeks, or there's also one called lenacapavir that will be every 6 months, and that'll be a subcutaneous injection. Is that something that you'd be interested in?
Absolutely. Injections have changed the game out here. From I've been on the Sublocade where I don't have to remember taking a Suboxone every day to not worrying about taking a PrEP pill every day. I really think it's going to be a game changer out there, and it's even helping me. I've been clean and sober for about a month now, and it's still helping me because now I got an HIV roommate that I live with. So it's either when you're on drugs or when you're off drugs, it's always good to have that extra protection.
I'm so excited to hear. So you're on long-acting injectable buprenorphine, Sublocade?
I'm about, yeah,
And did you get that at the SSP as well?
yes.
Oh, fantastic. So
It
definitely,
would be amazing to just come here and have to get both in one day.
I
If I
think I'm
wasn't,
looking at,
I'm sorry, if I didn't have a nurse giving me my pills every day, I wouldn't be taking them because, you know, I'm still have the junky intentions where I just don't want to take it. It's, but being where I am, it's easy to take it because I have somebody giving it to me. When I get a shot, I don't have to worry about it. And that, I'm telling you, is going to save lives out there. It really is.
yeah, you are here with a bunch of researchers at the National Institute on Drug Abuse, and I never think of yourself as a junkie, Sherry. You are giving us, I have a new grant idea from what you were saying, and you're educating the people who need it the most. So I'm really thankful for that. So you've had long-acting injectable treatment as well as for substance use disorder, as well as prevention at the exchange.
Yes, I have.
That's fantastic.
Yeah, you guys are amazing.
It's a privilege to serve, a privilege to serve. Do you have anything else you'd like to tell the people on the call before we switch over to questions?
There would be no reason not to do this, guys. Being a person with experience, like there's nothing that could go wrong with this. It is going to save lives out there, and we need it right now because it is everywhere. It's every people that you don't even think would have it. People don't tell you anymore. So they'll, they just they don't care. So any way that we could do to help and prevent this, and get it into an injection, it's really going to be helpful. And I'm telling you, it's going to save lives out there.
Sherry, I don't know if you see, but I've never seen so many hearts and claps before on a screen during a Zoom session. I can tell that the attendees are really, really excited to hear from you. And we're all so excited to hear that what we're doing has helped you. Thank you for coming. I'm sure I'm going to have more questions for you. I'm sure they're coming into the Q&A, but I will turn it back over to Kavi.
So thank you so much for moderating this session as well. And like you said, I mean, it is one thing for us to sit behind a laptop and come up with ideas and writing grants, but it's completely different when you're, working in the field with people who are experiencing these challenges, and to hear from them what their needs are, and to, figure out our research questions based on that is the best thing to do. And kudos to you all for doing the excellent work that you're doing through IDEA in Miami. So we have some questions here. Let me get to the there we go.
Kavi,
Okay.
Jamie asked a question in the hosts and panelists chat. If
Yeah,
I can
go
go
ahead.
to that first. So she wrote, can you talk about how you dispense, store, prep at IDEA? She did also note that my next grant was going to be Sublocade plus cabotegravir, and I'll have Sherry as my co-investigator for sure. So in terms of dispensing prep, the prescriptions that we write at IDEA, we have an amazing team of peers, people with lived experience, who go to the pharmacies to pick up the medications for the folks that we serve. That overcomes barriers such as having identification, competing priorities, just not really having the time to go to the pharmacy, withdrawal. We're able to go to the pharmacy directly and pick up the medications. It's also required in the case of the long-acting injectable medications that we'll be administering, and we now have a nurse on site to do that. The amazing thing about IDEA, so Sherry's currently living in a beautiful shelter that's across the street at Camillus, where she has a nurse that assists her with taking her medications. But at IDEA, we have mailboxes, we have pill lockers where the folks that we serve are able to store their medications. And in the era of just pervasive street sweeps that lead to all sorts of terrible health outcomes, as we all read in Dr. Josh Barocas's paper, storing people's medications on site at IDEA, where we have peers that can deliver the medications with syringes, or people can access their medications when they come to exchange syringes, has really been a game changer for us.
Yeah. So there's a question here about telehealth. What is the telehealth being compared to in your study? And also, can you talk more about the contents of the telehealth? Like how long people are, being cared for through this method of reaching?
Yeah, so we looked at telehealth for the delivery of care for HIV out of looking for a better way. We had a cluster of HIV infections that we detected in 2018 after implementing routine opt-out testing. And we were able to assist everybody in becoming virally suppressed, but for me as a provider, it was heartbreaking to see the stigma that my patients faced when accessing care in the traditional healthcare system, even at the public hospital. It was traumatizing for me as a provider, so I can't even imagine what it was like for them. They were treated just with no respect. That has changed, but I had an overwhelming sense that I needed to figure out a way to provide care for them in a comfortable and non-stigmatizing environment. So In the trials that we have, people either get access to teleharm reduction, which includes, so I'm just a small part of it, seeing me to do the telehealth visits that typically last about 20 minutes. They either get teleharm reduction, which is really centered on the relationship that the patient and the peer develop with frequent touch points, sometimes weekly, delivering medication and needs-based syringes. The control group treatment as usual is navigated to care at a partner clinic at an FQHC. So the peer takes the participant to the first appointment and assists with obtaining the first prescription. But after that, the patient follows up on their own. So that's the way the teleharm reduction trial for the treatment of HIV and prevention of HIV is. In the telehealth visits, it's really simple. We start with greetings. We're always so excited to see each other, even if we're separated by the internet. We ask about physical health, mental health, how things are going, taking medications, review any applicable lab work. We talk about substance use, develop a substance use disorder treatment plan if desired. When I offered a substance use disorder treatment plan on the visit earlier, nah, I'm good was the response, and I was happy to continue to form an HIV prevention plan, which was what he was interested at that time. We write the prescriptions. My team right now, I can see in the chat, is coordinating the patient assistance plan and doing all of the things that are necessary to overcome those barriers and get the medications to our participants.
Thank you. Jamie, I have a question for you. So what is the status with the currently available injectable PrEP, long-acting CAP, in the criminal justice system? Is it approved for use within the system? Or who covers the costs? And what do you see as an opportunity for the new class of drugs that are coming in?
Okay.
Like, in terms of practically,
Yeah. So first, it's really, thank you so much for the question. I mean, first of all, it's really important to say, well, I talked about people in the criminal legal system, but it's really systems, and there's a million of them, and they're totally heterogeneous. Whether we're talking about a county jail that's run by a sheriff or a state prison or a federal prison, every single context is different and is managed differently with different standards of care, which is a little bit scary. As far as I'm aware, and you saw the numbers for how few of them offer a PrEP of any kind, much less do HIV testing. As far as I'm aware, none offer injectable PrEP, and it will be a while. So from something being FDA approved to actually making it into a system behind bars, on average is 7 years. I mean, and that's any medication. Some of that has to do with cost coverage, and a lot of that has to do with slow wheels of progress and priorities. Yeah, so a long way to go. There are some research studies that at least develop some feasibility or qualitative data on the possibility of rolling out injectable PrEP prior to release from carceral settings, but so it's a start. But yeah, long way to go before that actually happens.
I really asked that question, keeping in mind the heightened risk people experience when they're released from justice systems into the communities. And if we have long-acting injectable that we can provide, it gives them some time to get their feet on ground.
Yeah, and
get connected. Yeah.
And we have models for how that can work, studies that Josh Lee and Sandy Springer have done, and others where they were getting extended release naltrexone prior to discharge from prisons and jails. It shows that it's all possible. It's and it works. There's linkages to care piece that need to happen on the back end, so we don't give people a one-time shot and then lose them forever. But I think I do think it's possible.
Yeah. I mean, we have evidence. So see, there are some systems and structural level barriers that we need to overcome in terms of who pays for medications,
Yes.
how it is delivered and all that. And just to put a plug in, we have a new initiative, our council approved idea of an initiative that I have put in the chat. Is Angela on the call? I don't know if she can talk about it. Dave, if you see Dr. Lee Vin on the call, maybe she can come in, say a few words. I don't know if she's on. That's okay. So it is really addressing structural and systemic barriers to PrEP uptake and implementation. We'll have like 2 different grant mechanisms, R01 and R34 clinical trial planning grant. But just to say, this is a concept approved for fiscal year 26. If you're people who are interested out there in the audience and on the panel, I'm just giving you a heads up so you can actually do some planning to do research in that space. So Dr. Tooks, you have another question. Can you talk about how you're supporting adherence to PrEP? Is there any incentive you provide? Like whether it is through, other support for housing or basic needs, and how do you address that?
Yeah, thanks for asking that. I also see nightmarishly my slides were behind. I must have forgotten to say next slide, please. Apologies for that if it was a little discordant. I'm sure Dave fixed it as it went on. So supporting adherence is definitely a key part of the teleharm reduction intervention. That's that cycle of recurrent motivational interviewing. What we really found, obviously people who are accessing SSPs care greatly for their health. That's why they're accessing the SSP, which is to get access to syringes and obviously to get access to life-saving naloxone. We've felt in Miami that when we reduce the barriers to accessing care, we really have a lot of success. It's really those structural barriers that our teleharm reduction intervention overcomes. The social determinants of health are still at play. There's still substance use disorder. There's still sometimes mental health disorders. It's really overcoming the structural barriers that human-made barriers that we've put in place. When we're able to overcome those barriers and facilitate access to care, the folks who use our program have done very, very well in taking their medications. We do round on our patients every week. We see when people last accessed their medications. If they are overdue, the team goes out with the medications to find the individual. There's often a agreed upon plan for meeting up and checking in and providing access to syringes and medications. The interesting thing about delivering care through an SSP is that folks, when they start to trust the SSP as a place to go to get access to syringes, they're going to continue to come back because we're able to provide them the things that they care about the most. And so when they come, that's a great opportunity for delivering medications. But it's really the ongoing motivational interviewing and check-ins and removing those tremendous structural barriers that are the key to delivering care. The teleharm reduction intervention is delivered by a peer. Our peers have lived experience. They are incredible. They understand everything that our participants are going through, and they do provide referrals to housing. I was really happy that Sherry's in housing now. Provide access to as many services as we can in the limited environment that is Florida.
Yeah, so connected to that, I have a question. So you talked about how PrEP linkage uptake fell over time, towards 12 months. So I was at a site visit in Los Angeles, and there was a study participant who became seropositive that day. He was not on PrEP, but he was on PrEP before, discontinued because he thought it was not necessary because he only has a single partner. So it just, makes me wonder about it looks like we need to, there needs to be a knowledge base and some way of sharing through community, like a support system where we constantly are working with people who are taking PrEP, to really discuss what, sometimes those are misinformed ideas or, beliefs that hurts them in long run. So do you have like any structures like that, like where they meet routinely to share like, knowledge that is, coming from research?
Yeah, absolutely. I mean, the first thing that you mentioned is this discordance between what the participants perceived HIV risk versus what it actually was. And I think that that's the biggest problem that we have in PrEP with people being retained on PrEP. Uh, Sherry will tell you, in Miami's #1 in HIV infections, 10% of the people who use IDEA are living with HIV. So there's more knowledge in a city like Miami that the prevalence of HIV is very, very high. I think that, when people come to IDEA, Miami is hot. They sit under a tent and they basically, have communion. And I think that a lot of people like Sherry serve as informal, community health workers talking about her own experiences. They're sharing all sorts of life updates, but also sharing key things that could be access to that could could facilitate access to care or interest in care. So the secret sauce of the teleharm reduction intervention as delivered by the peer, the sessions are all recorded, Kavi. Do not worry. The manual for the intervention will come out after the primary outcome and really go through all of the things that our peers talk about. Some of our peers are living with HIV, some of our peers have taken PrEP, and goes through all of the things that they talk about with people with substance use disorder in weighing the benefits versus the risks of taking PrEP.
Well, I have a question for all the panel here. Do you have existing protocols for PrEP that integrate mental health screening and referral that you use in your settings?
So in our research studies, we certainly we follow an SBIRT model. So we sort of screen for all conditions, including looking for people's need for mental health care, need for substance use disorder treatment. As we're kind of wrapping things around PrEP, I always kind of say like HIV doesn't exist in a vacuum, and often people need lots of wraparound support, and PrEP isn't just a prescription, right? People need lots of things to manage their HIV risk, not just a prescription. So yes, I will say it's sort of interesting that the clinical guidelines don't focus as much on integrated mental health screening and referrals in the way that the treatment guidelines do. And yet, as we heard from Sherry earlier, that the prevalence of trauma and lots of reasons to need mental health care are certainly there for people who are using PrEP as well, so needing lots of wraparound support. So as research protocols, yes. As clinical protocol, as far as I understand, there's no real standardized guideline.
I spoke of the results of the long-acting injectable qualitative paper that was done by Dr. Eddie Suarez, who's a psychologist who's on staff at IDEA. He's also a skateboard street medicine doctor. So I literally met him under a bridge downtown back before I entered the ivory tower and started doing this work. So mental health is key to all that we do. In that cycle, the physician meets with the patient, the psychologist can meet with the patient. And we have updated our SOR grant with the state of Florida to include medications for mental health. That was a huge gap that we didn't have medications for mental health that were covered. Our folks told us when we interviewed those Black people who inject drugs, they said one-stop shop. And so we found that we would need to deliver mental health care at IDEA as well. So now we will be able to pay for it. We have residents that we have helped get their full license, psychiatry residents, and hopefully we'll be able to cultivate our our mental health services as Eddie takes over the IDEA program on November 1st.
I hope you're looking at HIV care outcomes as well in that study, and we'll be thrilled to know what happened. So Sherry, I have a question for you. So how do people who you are with perceive PrEP? How do they take PrEP? Like, what is their idea of PrEP, or how do they view it?
To be honest, you gotta put the commitment in to take PrEP. Like, if you're not committed to taking it and you're not serious about taking it, then it's like everything else. You're just not going to want to be any part of it. I think it definitely should be advertised a little bit more. But most of my people that I know, the users, they know about it, but for some reason they just don't take it. Like, they're more, I don't think they have the knowledge about it, how serious it is. Like one of my best friends had HIV, and her biggest mistake, she said, was not taking PrEP, and she knew about it. Because she didn't think that she'd ever catch it. And now here she is, and she's not doing well. So like I said, I had shared needles with this woman. I have had the same sex partners with her. So it has saved my life. It really has. I believe that with everything I have. I just think that it should be advertised a little bit more. It should be, letting them know how serious this is, that their life is depending on it. That's what I think.
Yeah, I think we need to do more on the messaging.
Yes, definitely.
Really talk to people in a way that it gets through. I think we're not doing a good job in that space.
I think we also have to give people what they want. And we know at IDEA people want syringes, they want Narcan. So we've tried to remove structural barriers to make it a little bit easier for them to access things that I would like for them to have access to. It was very natural with HIV care. Everybody who has been diagnosed with HIV, for the most part, has been very eager to enter HIV care. I noticed in the teleharm reduction visit today how excited, after talking about PrEP, the person was to talk to me about Hep C treatment. So SSPs need to be looking at innovative ways to bring Hep C treatment and PrEP to the people where they are. 340B via HRSA and programs like that that will assist in providing these medications. But we have to listen to folks as well. And people want buprenorphine, so making sure that you talk about buprenorphine in the visits. That's what I found has been helpful.
I was just going to add too, like, we're talking about kind of going to where people already are and getting people the things they already need. Obviously SSPs aren't everywhere right now, so maybe that's not the sole solution. I see a question about that in the chat. But people who are I'm in the Northeast, right? People are injecting xylazine, and we're seeing people go into ERs a lot with skin and soft tissue infections. And every time someone interfaces with the healthcare system, that's an opportunity, to talk about other things they need. Well, can we get you treatment? Can we do overdose prevention? Can we start PrEP now? Can we at least do an HIV test? Like all of these things are sort of points of contact.
Yeah, thanks for pointing that out. I was going to get to that question next, because you know how it is with certain service programs. Not every state is supportive and is under implemented. There are policy barriers. So what would be a venue that would be, useful? So that was going to be my question, Jamie. You addressed it. So anywhere we can reach people. I mean, and I think about anywhere we have an interface with people who are prioritized populations. I mean, local venues. I mean, LGBTQ events. I mean, primary medical care is only one of many, opportunities that are out there. And I think we all need to, as researchers, come together to show that, there are multiple ways of reaching people who are in need of these very valuable services for HIV and substance use. and to show data that, this is how we can, get to the root of the problem. We're not tracking well on our targets for the ending the HIV epidemic. We are very behind, and nothing will change if we don't change our ways and we don't change policies about provision of medical care for people who are experiencing multiple disadvantages, social and economic as well, in addition to health. So this has been a very, very informative session. And I want to thank all the panel members for taking their valuable time out of their very demanding schedules to come on these panels to talk about PrEP today. Sherry, special thanks to you, because it takes a lot of bravery and courage to share your story with us researchers who really are out of touch, I would say, most of the times. So thank you so much.
Thank you. I really appreciate you guys even letting me on here and telling my story. Being sober now, if I could help save a life, I'm all in. So anything I could ever do to help, especially you, Dr. Tooks.
The
I'm here
privilege
all the
is
way.
the privilege is ours, Sherry. Thank you so much.
Thank you.
Well, thank you all. And I want to thank all the audience. Dave, can you put the slide up for the... Yeah, this is the initiative I was talking about, research to address systemic and structural barriers and facilitators to improve the HIV pre-exposure prophylaxis care continuum for people who use substances. The program contact for this initiative is Dr. Angela Lippin. And you can find more about this concept using the QR scan code that is provided there. This is going to be available for fiscal year 2026. The next seminar is scheduled to be in January 29th. The speaker is to be determined, but hope you all can join us in 3 months' time in the new year 2025. So I thank you all and all the audience for joining today for this NIDA HIV seminar. Thank all the speakers once again for providing your valuable time and sharing your knowledge on this very important topic.
Thank you.
Thank you.